Hi guys, my name is Joyce. Now I'm going to talk about gout and fibromyalgia. But first, let me discuss about gout. Gout is a common and complex form of arthritis that can affect anyone. It's characterized by sudden, severe attacks of pain, swelling, redness, and tenderness of the joint. Often, the joint at the base of the big toe. In addition, it is a type of crystal atrophy which is associated with chronically high levels of uric acid in the blood. Crystals refers to the fact that urate crystal is what causes the problem, and atrophy refers to the fact that the problem is in the joint. So what happens is urate crystals are deposited in the joint, and this causes the joint to become hot, swollen, and painful. Causes. Gout is caused initially by an excess of uric acid in the blood or hyperuricemia. Uric acid is produced in the body during the breakdown of purines, chemical compounds that are found in high amounts in the certain foods such as meat, poultry, and seafoods. Normally, uric acid is dissolved in the blood and is excreted from the body in the urine via the kidneys. If too much uric acid is produced or not enough is excreted, it can build up and form a needle-like crystals that triggers inflammation and pain in the joints and the surrounding area. Uric acid is a breakdown of products of purine metabolism. The problem in the gout is that there's an excess of uric acid leading to monosodium urine crystals and eventually deposition into the joint. And there's a couple of ways we can get excess uric acid. One is increased uric acid production. If the body is producing more uric acid, it can lead to a state of excess uric acid, and then if the body cannot be able to get rid of uric acid, so decreased excretion of uric acid, this could also lead to increased levels of uric acid as well. In increased uric acid production, it has excessive cell turnover, and it can be a condition like certain blood cancers. So if there's a lot of cells that are breaking down, those cells contain purine, and we can get an increase in purine metabolism and therefore excess uric acid. We can see this in a chemotherapy. So if there's chemotherapies being used that actually destroy cancer cells, there's a lot of cell turnover, can be a problem in hematological conditions such as polycythemia rubra. So where there's a high level of red blood cells or a lot of production of red blood cells, we can also get this as well, and we can see it in a certain genetic condition like Leishman syndrome. It is actually a deficiency of AGPRT, the enzyme that we talk about in the salvage pathway. So if there's a deficiency in that enzyme, the uric acid is not really able to process and reconvert it. So we can get this issue with an increased uric acid production. In decreased excretion of uric acids are excreted in renal system. So any disease of the kidneys can lead to a decreased excretion of the uric acid. NSAID can affect the kidney as well because it decreases excretion of uric acid, and we can also see a decreased excretion of uric acid with certain diuretics and acidosis as well. So because there's an excess level of uric acid, we can get more urate or monosodium urate being formed, and this crystal can accumulate in joints and then lead to the recruitment of macrophages, white blood cells, into the area, and this leads to inflammation to that area. So what happened is macrophages came along and they see these crystals and they think well and starting to phagocytize the crystal. Then it activates the NLRP2 or the inflammasome, causing an activation of caspase-1 and interleukin-1 beta, resulting to inflammation which cause a damage to the joints. Signs and symptoms. Symptoms of a gout attack may include gouty tophi, These are the subcutaneous deposits of uric acid under the skin rather than the joints, and these subcutaneous deposits occur around the small joints and connective tissue of the hands, ears, and elbows. The DIP or the distal interphalangeal joints at the ends of the fingers are the most affected joints in the hands. Gout presents with a single, acute, hot, swollen, and painful joints, and extremely important, the referential diagnosis is septic arthritis. Septic arthritis is quite dangerous to the joint and can be very destructive, so it is important to treat a hot, painful, swollen joint as septic arthritis until it's proven not to be related to an infection. Symptoms of gout may include sudden intense pain in the joint, typically the big toe or ankle, sometimes the knee, hands, or wrist, swelling and inflammation, feeling that the joint is very hot, red or purple skin around the joints, extreme cases alternating chills and fever, and extreme tenderness of the joint to even the lightest touch. The risk factors. So what are the risk factors for developing gout? It is very important to identify the risk factors because gout is very rarely occur in people without risk factors. However, many people have many factors are much more likely to get the condition. So the risk factors are male gender, because male are 2 to 6 times more likely than females to have gout. Older age, as the person gets older, the prevalence of gout increases. High purine diet or certain dietary sources increase the likelihood of having hyperuricemia or high level of uric acid in the blood. Certain beverages, such as alcohol, is the big risk factors, and sweetened drinks due to their containing high fructose, corn syrup, and sodas. And family history and genetics. Certain medical conditions also associated with an increased likelihood of gout include obesity, metabolic syndrome, hypertension, chronic kidney disease, congestive heart failure, hyperlipidemia. Some of this can be due to dietary issues and some of this due to the decreased excretion of uric acid. Another is medication like aspirin and NSAID, cyclosporine and pyrazinamide, diuretics and ethambutol. Diagnosis. A gout attack will usually go away in about 3 to 10 days, but the patient can feel better sooner if there's prompt treatment. Gout is usually diagnosed clinically or by aspirating fluid from the joint. It is important to exclude septic arthritis as this is a potentially joint and life-threatening diagnosis. When you aspirate fluid from the joint in gout, you'll see no bacterial growth. If there's a bacterial growth, this is a septic arthritis rather than the gout. In gout, you'll see needle-shaped crystal, negatively birefringent of polarized light, and further investigation, you find monosodium urate crystal and X-ray changes in gout. The joint space is usually maintained on the X-ray, able to see lytic lesions within the bone, punch-out erosions, and the erosions can have a sclerotic borders where there is a hardening or widening of the bone, and there is a overhanging edges where the edges of erosions hang outwards over the top of the erosions. Another, the doctor will examine the patient and do some tests such as blood tests. A blood test can check the level of uric acid, and a high level of uric acid doesn't always mean a gout. An ultrasound, this is a painless test, uses sound waves to look areas of uric acid. Treatment. To manage the condition, there's 2 aspects of management. First, managing acute flare. During an acute flare, the first-line treatment NSAID medication like naproxen or ibuprofen, and colchicine for the second-line option. The third line, where both of the above fail, is to consider is steroids. Colchicine is used in patients where NSAIDs would be inappropriate, such as patients with renal impairment or significant heart diseases. The notable side effect is GI upset, particularly diarrhea, which is a very common side effect. The diarrhea that the patient gets while colchicine tends to be dose dependent, so that if the patient is lower dose, it causes less upset than a higher doses. So if the patient develops diarrhea, try reducing colchicine dose and see if it improves the symptoms. The second aspect is prophylaxis. And one medication need to remember is allopurinol, and this is an xanthine oxidase inhibitor that is used for the prophylaxis of gout, and it works by reducing the uric acid level. It's important to advise the patient about the lifestyle changes which can really help reduce the risk to developing gout. This involves losing weight, staying well hydration, and minimizing consumption of alcohol and purine-rich foods such as meat and seafoods. Tips: don't initiate allopurinol prophylaxis until after acute attacks has settled. But once treatment with allopurinol has been started, then it can be continued during an acute attack. The nursing diagnosis for gout are the following: acute pain related to swelling joints, activity intolerance related to pain, hyperthermia related to inflammatory process, and impaired physical mobility related to presence of joint pain. The nursing intervention is to promote measures to prevent exacerbation. Urge the clients to drink 2 liters or 3 liters of fluid daily and to report any decrease in urine output. Teach the client about dietary modification to limit foods high in purine. Provide measures to promote comfort and reduce pain, such as maintain strict bed rest for 24 hours after an attack, and provide a bed cradle to keep bed linen off affected joints to help reduce the pain. Administer prescribed medications, which may include non-steroidal anti-inflammatory drugs, uric acid synthesis inhibitors, and uricosuric agents. Colchicine may be prescribed for acute attack and used in small doses for prevention. Nausea, vomiting, and diarrhea are toxic effects of colchicine and should be reported to the healthcare provider. The prognosis of the gout depends on the comorbidity of each individual. Mortality is higher in individuals with cardiovascular comorbidity. When gout receives proper treatment, most patients will live a normal life with a mild sequelae. For patients whose symptoms appear at an early age, they usually will have a more severe disease at presentation. For those who do not modify their lifestyle, recurrent flare-ups are common. Check out the next video, which about fibromyalgia.